Assalamualaikum, a very good morning. Oh dear. Okay. Assalamualaikum and a very good morning, everyone. My name is Heidi Muhammad. I'm a pathologist from Hospital Sultanah Bahiyah, Alusta. I'm very much honored to be the moderator for this session today. And before we start, I would very much like to introduce our speaker, Dr. Hemlata Kumari Gnanasegaram, or more affectionately known as Dr. Hema. So she's a consultant histopathologist in the Department of Pathology in Hospital Kuala Lumpur since 2015. She had underwent her Masters of Pathology at University Malaya many moons ago, and had served at several hospitals before landing in Hospital Kuala Lumpur. She's been to Hospital Serdang from 2009 to 2015. And Dr. Hema went for her subspecialty training in native and transplant renal pathology in London at the prestigious Hammersmith Hospital and St. Thomas and Guy Hospitals in 2019 to 2020. Upon her return, she's been the central person in establishing the electron microscopy reporting for native and transplant renal biopsies at HKL in conjunction with IMR at National Institute of Health since June 2021. So without further ado, ladies and gentlemen, I pass the floor to Dr. Hema.
Thank you, Dr. Heidi. First of all, I'd like to thank the IAP committee for inviting me to speak for today. Shall I share my screen?
Yes, Doctor. Yeah.
Okay. You're able to see me? See the screen? Okay.
Yep, we can.
Okay. So my topic for today will be stepping stones to a proper renal biopsy reporting. Over the years, I've noticed that based on some of the referrals and requests that come in, I see quite a lot of people are actually reporting, and the way of reporting has improved tremendously. I see a lot of interest as well put in by the participants, So let us just go through very quickly, yeah? Okay, so just for introduction, a medical renal biopsy report is equivalent to a non-neoplastic kidney disease biopsy report, okay? So it's equivalent to that. So basically we are dealing with a medical condition and not a neoplastic condition. So basically it represents a complex integration from clinical information, which is very crucial for medical renal biopsy reports, light microscopy, immunofluorescence, and EM findings if available. Okay. So why is it we need to standardize the renal biopsy pathology report, and why should we have a good renal biopsy report? Basically, it is to minimize all the lack of pathological parameters that will be required and needed to know, so that the therapeutic and the prognostic importance is given. And we also need to highlight the relevant pathological parameters that will contribute to therapeutic intervention and also for prognostic importance as well. Besides that, there is a big role between the communication between the pathologist and the clinical team. So that is it's very important and crucial, so that we actually can provide a good renal biopsy report. If you don't communicate well, and sometimes the necessary information is not conveyed to the pathologist, it becomes you can actually misdiagnose or probably give some lack or inaccurate reporting. So this is very crucial. We need to understand this. I think same goes for liver biopsies as well. For any medical related reporting, this is very crucial. So what is the role? What is our role? What is a histopathologist's role in providing a good medical renal biopsy report? So basically, we have to do a meticulous assessment. As you all know, renal biopsy reports, just like liver biopsy reports, they are quite meticulous, a little bit more meticulous because we have extra things like you have immunofluorescence, and now we have immunofluorescence paraffin sections. And now to make it more complicated, we also have electron microscopy input. So it itself is a meticulous assessment. And looking at a renal biopsy, you need to identify the morphological features and identify the pathology. And using this biopsy, you will also need to elicit the etiology of the pathology. So this one is heavily contributed by immunofluorescence findings, and EM is basically an adjunct. In certain situations, EM contributes quite a lot. Besides this, you also need to grade, estimate the degree and the extent of the disease process. Let it be active disease process or even a chronic disease process. You also need to classify the disease and conditions, and you need to communicate a proper communication, a two-way communication with the clinical team, so that this ultimately you produce quite a good report at the end of the day. And finally, produce a histopathological report. So all this thing has to go on just for one, imagine just for one report, you have to do so much of things. So that's how meticulous it is. Okay, so briefly, what should a renal biopsy report include? So I will touch again on this image later on, but I just want you to have a preview. Okay, so the first thing you need to do is, of course, clinical history and data. If you, in your system, if you have a location or a space where you can actually put in a quick history or data in your reporting, that is good. And if time permits, like in my setting, it's a bit also hectic. Sometimes I do try to put it in, sometimes we don't. So if you have the benefit of doing it, it's good to include it as in the beginning part of the report. Okay, gross description is very important, so that gross description is very important so that we always correlate with what is the biopsy tissue that is on the slide, and making sure the gross findings are consistent. Sometimes you may have discrepant gross findings, and that may cause a problem. So as for microscopy assessment, you have to do a detailed assessment based on, it's good to always give what you call a standardized checklist. So you go from glomerulus assessment, tubules and interstitium, and the vessels. So you don't miss out or jumble up things and fumble around in the report. So we keep it in this form of a manner, so it's easier, okay? Immunofluorescence study findings need to be included as well. And if you have an ancillary test, like for example, for instance, you need to do Congo rate for an amyloidosis, that's an ancillary test. So you also add it in. And you may not do ancillary tests for every other case, just for necessary cases, okay? An electron microscopy finding, if it is available and you have the, what do you call, the necessary and the necessity to do it, then it's okay, you can add it in. And finally, you need a diagnostic comment and final diagnosis. Over the years, many people have been asking me regarding this diagnostic comment, what to write. And people always have this difficulty in writing. They can come up with a final diagnosis, at least part of it. But when it comes to the comment, like, what should we write? What should we comment? That has been an issue. So I'll highlight to you later on. Okay. So first and foremost, clinical history and data is very crucial. So get a brief summary from the historian or the clinician and make sure it's verified and correct. And make sure the clinician is not giving you some other person's history, and make sure it's verified, okay? Since all of us have an LIS system, it's also good to check into the system, whether the results and everything, what are the latest results. They may put some in the form, they may not put some inside the forms. So it's good for you to also double check. Okay, so what are the most common indications for native renal biopsies? This session, we're only discussing native renal biopsies. We will not touch on any transplant biopsies, okay? So what are the common indications for renal biopsies? So number one, unexplained acute or famously known as rapid progressive renal failure. So these are emergency biopsies in which you are required to have a look at the biopsy as soon as it comes and at least give a preliminary result and try to produce a report as soon as possible. So this is known as RPGN, okay? Then you have a bit more relaxing conditions like nephrotic syndrome and significant non-nephrotic range proteinuria, where it is not an emergency, but you ultimately need to produce a report. Then you have conditions such as persistent hematuria. They could be microscopic hematuria or frank hematuria, in which the urological assessment has been excluded, and you would want to work on these cases. And then you have systemic conditions such as diabetes, lupus, SLE, or any autoimmune conditions and stuff like that, in which there is renal involvement. So these are the common, I just put in some of the common indications that you need to be aware of. Okay, so what are the relevant informations that we should grasp? And I've made this slide very busy. I've tried my best not to miss anything. We'll go through it. Don't worry, there's not much slides with very busy words inside. So let's go through them. This is very crucial because you need to always keep in mind all these things. It's like a fingertip thing that you need to remember. Like, have you done this? Have you done that? Have you checked on this? Have you got this? Have you got that? You may not know. There may be some relevant things that are not informed to you, and you have missed it altogether. So, for first and foremost, if you have a new onset rising creatinine, and if that's the main issue, you would want to know what is the baseline creatinine. Or has it been always raised like this, or in what's the trend? Is it like rising acutely or rising slowly? So this can indicate a chronic event or could indicate an RPGN, okay? And if you have a new onset of proteinuria, of course, you would want to know whether this is a nephrotic range or is this just subnephrotic range proteinuria. That would help us identify a few conditions, you see. And then you would want to know what is the duration of this proteinuria. Has it been long-standing? Has it been acutely happening? And what are the other parameters that can support this, like your urine FEME, your urine protein creatinine ratio or index, your 24-hour urine protein, so to verify this protein range. And then you would want to know your serum albumin. This is especially very crucial for conditions like, for example, FSGS, collapsing variant. You would want to know because serum albumin for those conditions are single digits, like, you get a level of 3 or 4 or 5, so that would actually support your diagnosis. If you're in doubt, it would support your diagnosis. LFT is good because it tells you the total protein levels and you can correlate from them. You would want to know underlying medical diseases, like, for example, hypertension, diabetic, any underlying proliferative disease, long-standing infection. All this could contribute to the renal biopsy findings. Any therapeutic or medication history, any over-the-counter drugs, these are very crucial. And you would also want to know on what is the serum urea, cholesterol, C3, C4, A and A levels. So these are all autoimmune markers. And if it permits, if you have the chance of getting to know the ANCA levels, that'd be good, or anti-GBM. And if you don't, and if the biopsy shows features that are supportive to this, then you would want to know these results as well. Okay, and any recent infection now, since we know that COVID itself can cause certain morphological changes in a renal biopsy in the kidney itself. So it's good to know whether there's a recent history of COVID, hepatitis, HIV, and things like that. Other things are like infection, obstructive, and family history of CKD and end stage. So all in all, in a nutshell, there are a lot of things that you need to know. If you keep it at the back of your mind or somewhere along you have a checklist, then it's good that you would not miss anything. Okay, let's go to the gross description. So ideally in any report, you will need to mention the number of cores and what is the length of the core. I think this is a routine practice for every one of us. And as for the immunofluorescence, it's also good to mention how many cores and what is the length of it, okay? And the same goes for electron microscopy. So gross description, I think most of us don't have any problem. This is a dissecting microscope. So several centers have it, I know, but several don't. And I understand there are some centers whereby the tissue comes fresh and the pathologist actually dissects the tissue. We don't do it in our center, but we only do it for the electron microscopy cases. So if you're handling this, you need to handle it very gently, preferably using a small needle, no blades or no forceps used. Sorry, Anna. A dissecting microscope is very good because you can identify the number of glom. And if you are firsthand going to actually cut up the tissue into pieces and decide which one is going where, then a dissecting microscope will be very useful. So, and the other thing is that, for example, when you look at the dissecting microscope, this is how the tissue looks like. So if you have fat, it would look like this, and this would not contribute in any way to our input in our renal biopsy. Okay, it's not going to contribute. This is basically just fat and a huge chunk of blood clot. And if you have tissue like this, then you can see number of glomeruli. So you know that these are relevant tissue and suitable for whatever additional test that we're going to do now. Okay, so that's the benefit. Now, for those centers who are actually dealing with these tissues, so just for a reminder, if you receive one call, first you procure the cure. If you, in case you're doing it for EM, the tissue need to be procured at the edges, removing at least 1 millimeter cubes from both ends. So you have an example here. Okay. So you can have an example here if you're having only one core. Okay. And then you place them in the glutaraldehyde. That's for those centers which have EM. And then for immunofluorescence, the first core can be cut into half. So you have a cut here. Okay. And the larger piece is sent for light microscope, and the smaller piece is sent for IF. And when you have two cores, what happens is that if the second core is obtained, the ends of the cores again taken for EM, and then when you divide them, the larger piece now will go for IF, and the smaller piece will go for light microscopy. Now, this is just what you call a guide. This is just a guide in how you want to procure the tissue for those centers who actually receive the tissue, and you will need to do this sectioning yourself. Okay, so we have 3 types of specimen, just to very quickly go through. Obviously, we receive tissue for paraffin fixed sectionings. So this one is received in 10% neutral buffered formalin like this. And you have a detailed history in the pipette form. And then for tissues that come in for immunofluorescence studies, the tissue is wet in phosphate buffer, not soaked or not what you call drowning in a phosphate buffer. It's just wet only. Yeah? Okay, and not empty, not an empty where the tissue gets dried up. So you need to take note of this because all this will contribute the findings that we see subsequently. And for tissue fixed in glutaraldehyde, it needs to be put in this depends on the center's method of doing it. You basically need to get the tissue into the fluid, and then we usually put it in another container. So within both the containers are labeled accordingly. So this is how the glutaraldehyde container looks like for us. So I think for places like UPM and UKM, they have a different style of doing it, but ultimately the concept's the same. Okay, so once the tissue has been crossed and subsequently processed, and after embedding in paraffin wax, the tissue in paraffin wax is cut into several serial sections. So at least we get about 8 to 16 paraffin sections. Now, different centers have different styles of doing it. Now, why do we do this? Why do we do so many special stains and so many levels? And the reason is mainly because we don't want to miss a lesion. And some lesions where we have to look at so many levels, as you know, the tissue is quite thick, and we may miss certain important and crucial findings. If we just look at it like we are looking at any other biopsy, then it's 1 or 2 levels and we miss it. So that's the reason we also do so many levels, and with different colors and different special stains, you identify different components like sclerotic areas, active lesions, necrotizing lesions. All these are benefited by, all these things are seen in various of the stains in different manner. Okay. Now, the thing that I want to highlight is the thickness for each of the paraffin section is 2 microns. If we do it thicker, then what happens is the tissue becomes too thick and you would miss the lesion, or you would find it very difficult to actually identify the lesion, and you may actually misdiagnose it as something else. Like, for example, if it's too thick and the tissue and the glom is like folded, you end up calling it FSGS when it's not really an FSGS. So this I have personally seen for some of the referrals that we receive. Sometimes the tissue is very thick and we have to recut again to make it thinner. So the cellular details identified at a certain level. So if you make it too thick like a normal tissue, then it becomes very difficult for us. So for us in HKL, the light microscopy and the immunohistochemical staining procedures, the sequence is done like this. So the first 2 levels like this are put into HNE, followed by pass, silver, MT, and then go back to silver and HNE. So there's a reason why we do this. So we will go in a sequence. These slides are taken in a photo where they're not according to the exact sequence. Just forget about this. I'm just showing you the images here. They are done in such a manner so that whatever lesions that you see, when they come back again, you get to see it in a different color or a different stain. So that would benefit in us identifying the lesions. Okay. In different centers, like in UK, they would actually do a slide, skip a slide. That means at certain levels, like if you do level 1, level 2, level 3, the 3rd, 4th, few levels will be removed as unstained and kept aside, and then they will stain the 7, 8, 9 levels. It goes like that, so different centers, different styles. I suppose if it is good, because let's say if you see a granuloma in level 2, and obviously after you have already done a few levels, you would want to do a ZN stain on it. And if you don't have a subsequent unstained level, you can't do it, because probably in level 7 or 8, that granuloma doesn't exist anymore. So this is beneficial for them. That's the way in certain centers do it. But for us, this is how we're doing it. So good histology always demands a very good fixation. So you cannot have delayed fixation. You will get very improper, imperfect slides and what do you call tissue biopsy. And if you underfix it, it's also poor. Okay, but formalin is one of the best and most suitable fixative for renal biopsy tissues. Okay, and then you have immunofluorescence studies where the tissue is reacted directly with fluorochrome conjugated antibodies, a direct IF method. And now this one we do it with fresh tissue. And now we are also, I think many centers are already beginning to do on paraffin sections. So that's a good thing. But only thing is that doing IF on fresh tissue versus paraffin section is totally different scenario. It's always best to do IF on a fresh tissue. If you want to compare it with paraffin section. Paraffin sections, IF findings have two major problems I see. One is the intensity of staining. Even if it is a deposit is there, the intensity of staining is always not very strong and they'll be lighter. And the other thing is that you have a lot of serum staining. That means a lot of cross reactions. So this is the problem with paraffin section. So if you're practicing paraffin section immunofluorescence, you have to be cautious about it. Okay. And how are these slides stored? They are stored in negative 32 degrees to negative 37 degrees freezer without exposure into light like this, and maximum 3 weeks. Preferably once the IF slides are done, have a quick look at it. Don't keep it too long, because if you keep it too long, the immunofluorescence will fade off over time. And when you're viewing the immunofluorescence under the UV light, make sure you don't leave the light too long exposed onto the tissue. If you do that, the immunofluorescence impact will also start to shallow down and you can't see the image after that, okay? Now, the complete nephropathological workup assessment includes all this, as we all know, light microscopy with all the special stains, IF, IgG, IgE, IgM, C3, C1q, with the help of fibrinogen, and now with kappa and lambda, EM if available. Okay, so far we are good. So now we proceed to light microscopy. So you need a good sample. Preferably, if you're looking for focal lesions, you will need at least a minimum 25 glomeruli. That is for focal lesions, but this rule does not apply for every condition. Okay, if you have at least 25 glomeruli, the studies show that at least you have more than 95% of chances of detecting the lesions, especially in conditions like FSGS. Okay, now let's say if you have other conditions like in membranous GN, even if you have one glomerulus is quite sufficient actually to make the diagnosis. This I'm referring to is primary membranous glomerulonephritis. Okay, so for adequate sampling, at least if you are not looking for very, very focal lesions, adequate assessment of severity, distribution of lesion, at least I would prefer to at least see 10 glomeruli. 8 is minimum for IgA conditions. So at least 10 glomeruli, I think that's good. If you have 2 cores, that's even excellent. Okay, and preferably if you're looking for FSGS lesion, you want to have the area of the juxtamedullary versus cortical region. You need to have that junction between the cortex and the medulla, because usually FSGS, early FSGS, starts off there. So that's one area that you want to see. Okay, and subcapsular cortical sampling, which is commonly done. I mean, if you can't avoid it, if a biopsy comes in, sometimes you do see it. But if it is the main thing that is sitting in your tissue biopsy, then don't overdiagnose that area. Whatever you see there, you have to take it with a pinch of salt, because often that is where all the aging features or hypertension features or any non-specific scarring will often occur. So that is actually subcapsular region around this area here. Okay, so try to avoid overdiagnosis, overspending your time assessing these kind of areas. Okay. Okay, now we are going down to the biopsy reporting now. Now, I have divided the glomerular assessment into this manner. So I think this will benefit easy and make it easy for you to identify as well. First and foremost, you need to identify number of glomeruli. So that is need to be documented very clearly in your report, and this is very important. Okay, and other things that you see, you are going to semi-quantitative. Renal pathologists love to count everything we see. We enjoy counting, so never forget your calculator with you. Okay, so semi-quantitative finding, either you keep it in numbers like 3 out of 12, 3 out of 20, or you give a percentage. Okay, like 30% of focal lesion of this, 30% of that, that kind of thing. So semi-quantitative. Okay, next thing is you need to identify what is the terminology global versus segmental. I'm still getting people mixing up these lesions, misdiagnosing global versus segmental and focal versus diffuse. So global versus segmental is within the glom. I'll show you in a diagrammatic manner. And focal versus diffuse is a pattern involving the whole tissue. And I have also divided the glomerular areas into active lesions and chronic lesions. So if you remember this, I think it should be easy for you to handle in any situation. Let it be native or even transplant. You can use this as a guide, and I think it's quite helpful. And lastly, you also address pattern of injury. Now, pattern of injury is crucial because ultimately you need to come up with a diagnosis. So pattern of injury is crucial for you to understand, especially when you don't have a proper etiology. Okay, so pattern of injury here is a reference to glomerulonephritis, not so much for global sclerosis, what they call FSGS and minimal change. I'm referring this to a glomerulonephritis conditions. So number of gloms, semi-quantitative assessment, global versus segmental, active lesion versus chronic, focal versus diffuse, and pattern of injury. Okay, so that's a normal looking glomerulus. I think most of you know this. That's a Bowman capsule. That's your vascular pole. This is a urinary pole. The one that's popping out on the outer surface are your podocytes. Okay, they're always outside. They're epithelial. They're visceral epithelial cells. These are parietal epithelial cells on the inner surface of the Bowman capsule. This is just to recapitulate, and give you a flashback memory of how a normal glom looks like. And then whatever that branches out like a tree over here, these are the mesangial component. A lot of people still are confusing with mesangial hypercellularity versus endocapillary hypercellularity and still mixing up a lot of lesions. Okay, so this is the mesangial area with mesangial matrix and cell. Okay, endocapillary is over here. So this is your capillary loops. You have loads of capillary loops. They always form like a flowers, like petals, So this capillary loops, the inner cell over here is your endothelial cells of the capillary loop. So whatever that occludes here will be endocapillary. I'll show you some images. Okay, so this is a normal glom. So this is an EM image. So slowly over time, we have to get used to seeing this since we are getting more EM material. So this is your glomerular basement membrane, your GBM, which is made up of 3 layers. Okay, you have your lamina densa in the center. The outer one is known as lamina externa and your interna. This is your fenestrae over here. This is your endothelial surface over here. That's your endothelial cytoplasm. And this is your podocytes, food processes, which belong to the podocyte, which is out here. That's a red blood cell, okay? I am not sure what has happened. Okay.
You can't change slides, is it, Emma?
I'm not sure, it just kind of popped out. Are you okay now? Can you see my slide?
You're still on your normal EM slide?
Yeah.
Yeah.
Okay, you move.
Okay.
Okay, I don't know what happened there. Okay, so let's understand what is focal pattern and diffuse pattern. So when we have an entire strip of tissue, focal is when you count the total number of glomeruli and the number of lesions that you see have to be less than 50%. You address it as a focal pattern, okay? Focal pattern. So this is for the whole core. Please don't confuse this. Diffuse pattern is anything that exceeds more than 50%. That means total number of glomeruli and the number of glomeruli involved with a certain pathology. Doesn't matter what is the pathology, either it's active or chronic or whatever it is, doesn't matter. That automatically it becomes a diffuse pattern. Okay, that's for focal and diffuse. And then we go for glomerulus. This is segmental. So segmental is when we are referring to a single glom. When you have less than 50% involvement of any particular pathology, it is known as a segmental lesion. Let it be a FSGS segmental, or let it be segmental endocapillary proliferation? It doesn't matter. As long as it is less than 50%, it's segmental. If it is global, anything more than 50%. Okay, so this is just a diagrammatic image so you can understand things. So let us understand the lesions in the light microscopy. So I told you just now that I have divided it into two components, active and chronic. So if you keep this as a checklist, I think you will never go wrong. So these are the active lesions. Crescents, cellular and fibrocellulars are under active lesions, crescents. Fibrous is unfortunately comes under chronic lesions. Okay, endocapillary hypercellularity, or famously known as endocapillary proliferation. Double contouring, whereby the double contouring is occupied by subendothelial deposits, wire looping with pseudothrombi, fibrinoid necrosis, cardiorexis debris and nuclear dust, and neutrophilic infiltrate. So all these are active lesions. We will go through them. Now, I've put a star for certain things, like for example, your crescents and fibrinoid necrosis. Now, if you see them, always make a habit of giving a semi-quantitative number. That means 3 out of 20 fibrocellular crescents, 3 out of 20 cellular crescents. Please document it until the very end of the report. I think this is very crucial, as same goes for fibrinoid necrosis. As for the rest, we semi-quantitate them as an active lesion overall. So this is like, for example, in lupus, for instance, I will show you in images. So if you can do this for crescents, especially the cellular and the fibrocellular and fibrinoid necrosis, they carry a higher weightage for active lesions. So hence the reason why we need to highlight them, and especially in conditions like crescentric GN and so on. Okay. Another thing that I want to highlight, I noticed many of the referrals and many people who are actually attaching here still getting confused with this overcounting thing. That means if you have one glomerulus with 2 lesions, please do not overcount the glomerulus. So let's say if you have a glom with a segmental endocapillary hypercellularity, and the same glomerulus also has a sclerosing lesion, like for example, small segmental glomerulosclerosis. What happens is that the relevant pathologist tends to count the lesion as, oh, I have one active lesion and another sclerosing lesion. That is wrong. You just need to count it as 2 lesions in one. That means the number comes back to 1. So don't double count it. Don't add on the number, especially for lupus. If you want to count your NIH scoring, you don't go and count your endocapillary hypercellularity, put as 1 lesion and segmental as another lesion. They just become one pathology. That's it. Okay, you describe it together. Don't double count it. This one is very crucial to remember. Otherwise, it will become inaccurate. So I'm showing you some of the images of active lesions. So this is an endocapillary hypercellularity. You can see that these are full with cells occupying the capillary loops with mesangial cells and occupy the entire capillary loop. So you have a nice segmental endocapillary hypercellularity. Here the GBM is thicker. You have some spacing here. There's another area with endocapillary hypercellularity. Looks like almost more than 50% involved in this glomerulus. So it becomes kind of like a global endocapillary hypercellularity. Okay. This is a crescent. So we have a nice cellular crescent in your H&E stain. You can see the crescent over here. And you have this highlighted in silver stain. Now for crescents, the best stains to highlight them will be your pus and your silver. They are excellent stains to identify all forms of crescent. So use it as a guide. Don't be scared, just use it as a guide. These are very good images. So as the crescents becomes very big, the tuft in the center becomes smaller and smaller and smaller. And sometimes when you have the section cut this way, what happens is that you only see the crescent. So everything is light in color and occupying the whole surface. So that is still a form of a cellular crescent. Okay, this is a glom in which you have an endocapillary hypercellularity going on here, a small crescent, and also a nice necrotizing lesion. Now, what are the ways to identify a necrotizing lesion? When you are not sure, look at the MT and you will see the fibrin going strands in strands. They won't be like a nice endothelial, subendothelial deposit. They will be in strands and all over the place. That's one way of identifying it. And you can also benefit by using the special stain called Marshall Scarlet Blue, the MSB stain, and this can also help you identify these lesions. Now, yeah, besides this, if you look at this tuft here, you can see that this is only mesenchymal hypercellularity here. Only the mesenchymal cells are increased. This is not endocapillary hypercellularity. The loops are quite open. Okay, that's the clue. Okay, now what's happening here? So here you have capillary wall, which is very thick and very, what do you call, lumpy and pink. Obviously, there's something going on. There's definitely either it's going to be a subendothelial deposit, as you can see here, or perhaps it is a very long-standing membranous. So how do you confirm it? Look at the empty stain and the silver stain. Okay, now this lesion over here is occupying at least about slightly, perhaps less than 50%. So it becomes a segmental lesion. And at the same time, you have a lot of mesenchymal proliferation as well. Huh? Okay, so this is your empty stain, which demonstrates your very nice subendothelial deposits over here. But at the same setting, you also have subepithelial deposits coming out. So which means to say, we have two lesions here. Okay, you have subepithelial lesion and subendothelial lesion. And this is 50%, maybe perhaps less than 50%. So it's a segmental lesion. Okay, and EM, this is how it will look like. So you have nice subendothelial deposits on the inner surface. Okay, here I don't have an image of a subepithelial deposit, but this is your subendothelial deposits over here. Okay, so we have roughly looked at all the active lesions just now. Let us address some of the chronic lesions. So you have only three things, basically, very simple. Global sclerosis, you need to assess them, segmental glomerulosclerosis, and fibrous crescent. And all of this have to be in semi-quantitative form. Either you give in numbers or percentage, okay? So if, for example, in FSGS, you may want to identify the location and nature of it. So if you have a tip lesion or perihilar or cellular or collapsing variant, you need to highlight it. For other conditions, generally you just identify a segmental lesion. But if you do have a collapsing lesion, in, for example, even in lupus, it's good to identify them as well. Okay, so very quickly, this is a nice global sclerosis. This is a segmental lesion, very clearly seen. I think this is not too difficult. And this is a nice collapsing FSGS in which the glomerular tuft has already closed up on itself. Okay, and you have podocyte proliferating. Okay, and this is nicely highlighted in silver stain. You can see the collapsed glomerular tuft and podocyte highlighted over here. So this is podocyte hyperplasia over here. Okay, this is a collapsing variant. Now, the additional things that you can highlight is if you have enlargement of glomerulus, glomerular ischemia, any hypercellularity, whether you have it with nodularities, that means like in diabetic, or even in light chain disease, you have a nodular formation in the mesenchyme, or you don't, or you do, you need to highlight them as well. A lobulation of glomerular tuft, this is commonly seen in MPGN conditions, and duplication of GBMs. This duplication GBMs, if you have a subendothelial deposit, they will become an active lesion. If the duplication is because of a very long-standing membranous, so you have a lot of spikes and membrane regulation, then it does not become an active lesion. Okay, it's just membranous. So this is an ischemic glomerulus. So this is how it looks like, where the tuft kind of wrinkles up on itself, and you have a periglomerular fibrosis. This is another lesion which is showing you extensive nodularity in the mesenchyme, so expanded and nodularity. Okay, so this is another thing that you can highlight. So these are the additional findings you can put in your report. Now, other patterns of injury which are nephrotic. So now we've come to the last part of the pattern, which is the pattern of injury in the glomerulus, which is, I've actually just stressed more on the GN part of it, just to not miss out a little bit on the podocytopathies and others. I will just touch a little bit on the membranous component. So this is how a membranous pattern of injury would look like, where you have a GBM that is thickened throughout, the whole loop. In this condition, this is a secondary form. So that's why you also have some mesangial hypercellularity in the center. Okay, marked mesangial hypercellularity. Generally in primary membranous, you don't have this mesangial hypercellularity. So this is something you typically see in conditions like lupus, whereas in primary membranous, it's quite quiet and all they have is just loops which are very thickened and all around. So the silver stain will help you enhance the beautiful subepithelial spikes and membrane regulation that you see over here and clearly demonstrate the subepithelial spikes and deposits. You can also do EM if it is available. This is how they look like in subepithelial deposits over here. So you can see large chunks of them. And for IF, if it is typical primary membranous, it will be like this, granular positivity for IgG and C3. So these are some of the lesions that you see. Now, for pattern of injury for nephritic conditions, there are a list of them. So you want to identify, there are a list of them. You start from very mild, minimal mesangial changes, right? From mesangial proliferative changes, active lesion, exudative, membranoproliferative, necrotizing, crescentric, sclerosing, and a combination. Now, what you need to understand is so that this will make your life easy. Once you identify the pattern and it's easy for you to make a conclusion. So we just very quickly run through the mesangial proliferative pattern, which you know very typically, like for example, in IgA conditions where you have mesangial proliferation as the main feature. But IgA can have all the other lesions as well. But mesangial proliferative is a disease over here. So this is a process. This is a pattern of injury for IgA. So this is one. For endocapillary or very proliferative pattern, which is like this, you have heavy endocapillary proliferative. So this is a proliferative, an active lesion that you can find in any condition, let alone be IgA or even in lupus. So this is a form of pattern of injury. So it's an active pattern of injury. Okay. Earlier we have identified the lesion. Now we're looking at a pattern of injury. So pattern of injury, this is an active proliferative pattern of injury. Okay. Necrotizing pattern, for instance, in ANCA-associated vasculitis. So you see a florid necrotizing lesion. If it is involving part of a segment, we call it segmental necrotizing lesion. If it is a global, if this is in this condition, this is a global necrotizing lesion, commonly seen in ANCA-associated GN or pauci-immune ANCA-associated GN. Okay. So Mason's trichrome stain also highlights this, and this is very good and beneficial. So you can see the fibrin strands and the fibrinoid necrosis in strands kind of pattern. Okay. IF will be obviously negative for pauci-immune ANCA-associated. Then you have the famously known as the MPGN pattern. So MPGN pattern is basically two things. You have diffuse capillary wall thickening and you have mesangial proliferation. And you can have pseudothrombi depending on what is the condition. So if you can identify these two things which go hand in hand, and then if you look at it, it has kind of a lobular flowery pattern. So this is an MPGN pattern. So this is membranoproliferative pattern of injury. Okay. Now the etiology can be variable, variety of etiology, right from infection to autoimmune, cryoplaques due to hepatitis. It could be a variety of patients. So this is in empty stain where you can see the lobular accentuation all the way through. Okay, and very nicely demonstrated in silver stain, your double contouring which goes all around. Okay, so this is an MPGN pattern. Also, just to enhance the lobular accentuation, I've put a few other images for you on. Okay, what is exudative? Exudative pattern is typically very specific for post-infectious. When you have loads of neutrophils occupying the glomerular tubes, loads of neutrophils and loads of inflammatory cells. So basically very specific for post-infectious. We look for exudative pattern. This actually describes them quite well. So the guideline is for glomerulus, at least you need to mention the total number of glom, percentage of global sclerosis, segmental sclerosis, ischemic, whether the lesion is focal or diffuse, segmental or global, all the hypercellularity. The crescents, you need to highlight percentage. Fibrinoid necrosis, you can highlight percentage. And a lot of the active lesions, you need to highlight. Any GBM thickening, any disruption. So these are the guidelines for you to write down for your glomerulus reporting. It is a handful, it is a mouthful, in fact, but I hope if you have this lecture notes, this would guide you a little bit, So we have left the glom aside. We'll quickly go on to the tubules and interstitium, which is often much forgotten. And sometimes this can be actually the main dominating pathology. Yeah? So for tubules and interstitium, basically you need to identify the chronicity. So you score it on the cortex, not on the medulla. You assess it, anything less than 25% is mild chronicity. Anything more than 25%, up to 50% is moderate. Anything more than that will be severe. So this can be a good indicator. Sometimes if you have active glomerulonephritis going on, you will realize that the amount of IFTA that can contribute could be part and parcel of a GN. Then the interstitial infiltrates, you want to identify what are they, eosinophils or mononuclear cells. If there is an acute tubular injury, you need to highlight as well. If there are crystals or any specific crystals or any casts, you will need to highlight them as well. For example, crystals will be like urate, oxalate crystals or calcification. Your intraliminal casts can be like red cell casts, neutrophilic casts, myoglobin casts, so all this will be included. And TIN conditions that you can mention. So I just show you some images. These are chronic areas with heavy infiltrates. This is actually just a fibrous tissue, which is like part of a capsule. So this is a chronic area. And this is mild acute tubular injury changes. You see the tubules dilated, but this is a chronic area in between. Tubules dilated here with flattened lining epithelium. Okay. This is acute tubular injury changes where you have lining epithelial cells showing marked regenerative with loss of nuclei over here. Some of them have loss of brush border. So this is a typical feature of acute tubular injury. This is what we call, this can be also commonly seen in acute tubular injury where you have a lot of vacuolation inside. So you can also identify them as part of acute tubular injury. Red cell cast always indicates that there is an underlying glomerulonephritis. If you see it, please document it. Neutrophilic cast, always, if it is significant, then it will always give you an idea there is an ongoing pyelonephritis or a bacterial associated infection. It's always good to highlight in your report. These are oxalate crystals where you look at them in H&E and you polarize them under polarizing light and they will look like this. I don't have an image for urate crystals. They don't highlight under polarizing as well. These are ropey looking casts which are often missed in any RPGN condition. If you see them, very quickly do your myoglobin marker and they will pick up very easily. So this is a myoglobin cast. A common cause for RPGN. This is a lambda light chain cast in which this patient presented as an RPGN. So you can do the necessary stains to identify them. So for guidelines for vessels, basically you have what we call vasculitis and TMA. We have hypertensive associated changes as well. Need to either address the thickening of the vessel, either the fibrosis is severely thickened, how bad is the intimal thickening, how bad is the narrowing, is it mild, moderate, or severe, and if you have an arteriolar hyalinosis, it's also good to mention. Are we running short of time?
No worries, Dr. Hema, please carry on.
Okay. Okay. So these are some of the images I just wanted to show you. When you have arterioles, this is an interlobular artery, a small interlobular artery. Actually, these are arterioles. These are known as fibromyxoid intimal thickening, commonly seen in hypertension. So don't miss them. It's often missed. I have a number of referrals which have actually missed these lesions, and this could be the main source of diagnosis for the report. So please don't miss them. If you have a fibromyxoid and it myxoids and your fragmentation of RBC, they can actually occlude the vessel and form a TMA. So you can see that these vessels are quite almost occluding and you have an ischemic glom adjacent to it. This is a long-standing chronic fibrointimal thickening. It's just long-standing and part of atherosclerosis. You have a bit of a lumen there. So these are some of the other lesions you can find. This is a typical TMA when you have fragmentation of RBC with fibrinoid necrosis of the wall, and the corresponding glom is ischemic. And if this is affecting the afferent arterioles, then this glom will be ischemic. If it is the efferent arterioles, the glom will be very congested like this. Okay. This is a Mason's trichrome and a MSB stain that can really help you identify TMA. So you can see how it highlights the TMA component. Okay. So immunofluorescence studies basically is very important because you want to identify the etiology. So this is best, as I told you earlier on, done on IF tissue. So I have put for you a list of things that you can go through at your leisure time. What are the things that you need to identify or remember when you're addressing any immunofluorescence? Number one, your optimal panel, you have already covered IgG, IgM, IgA, C3, C1q, fibrinogen. We don't have albumin here. Kappa and lambda, okay, for light chains. It is need to identify whether you're doing it in fresh or paraffin, you need to inform or put it in your report. Please indicate and always make a good habit of indicating how many glomerulus you actually see in a fresh tissue or in your IF tissue. Okay, yeah, it's good practice, and it is also good. At least we know that the IF is the finding is memang strengthening lah for the report. Okay, and indicate the staining location. Is it the glomerulus, tubules, interstitium, or vessels? Scoring, as we all know, you give a scale 0 to up to 3+ scales. For those of you who are practicing renal pathology, you would know that how to give your scoring based on intensity. Okay, and the staining pattern is important. So either you identify it as granular or linear, especially for anti-GBM cases. For linear accentuation, mostly for diabetic. Basically, they look linear. Okay, and smudgy you can get in fibrillary GM. Then this one is optional. Even I don't really practice this location, focal or diffuse or segmental. It's a bit too much. If you can highlight it, it's good, but it's a bit too much as well. Location is very important. You need to identify whether it's in the mesenteric or capillary wall or both. This is important, especially for primary and secondary conditions. So just internal controls. Don't overcall your C3 positivity because they're commonly seen in the arterioles. Kappa and lambda light chains are also commonly seen in PAM phosphoproteins. And segmental lesions often have trapping for IgM and C3 and C1q. Don't overcall this positivity and give a wrong diagnosis at the end of the day. So must remember that there are certain things that you can actually see which are actually non-specific. So this is a full house pattern, a very granular and full house, commonly seen in lupus. You have capillary wall involvement with mesenteric, so very nice full house pattern. This is a negative glomerulus, but it is bright. So we call this autofluorescence. It is bright, but it is not fluorescing. So don't call this bright as a positive lesion as well. So that one need to bear in mind. Several times the bright one has been identified as positive, which is wrong actually. And then this is memang fluorescing, at least a 3+, and it's granular all the way through, both mesenteric and also capillary wall. This is IgA pattern, so you have only mesenteric positivity. So this is not going along the capillary wall positivity, just the mesenteric positivity. Okay, and this is linear positivity, no granularity for anti-GBM, and you often get it in kappa and lambda as well. Okay, this is kappa. Now we are doing kappa and lambda. Most of you are asking me, how do you actually interpret it? So basically you compare kappa and lambda at different areas. Which is more dominant? If you have a scoring of 2+ extra, that means lambda is 3+ and kappa is 1+, then it becomes significant. If it is just slightly like 1+, slightly extra, then it is not significant. So for this case, this is a lambda light chain crystal disease. So what we have is that the kappa was completely negative and your lambda is very strong. So this is significant staining. Okay. Ancillary tests, you know that C4D can be used for membranous. So you can see the granular positivity going through the capillary walls of the GBM. Okay. And this MSB I've already explained to you all earlier on. This is amyloid deposition, whereby congorate stain is beneficial for any amyloid deposition, and you polarize it under the microscope. This is kappa IHC and lambda IHC, where sometimes you can use it to help you also to strengthen your IF findings. Okay, so your kappa is negative within the CAS and lambda is strongly positive here. So finally, we're coming to the final part, which is the final HPE report. You've done all this meticulous assessment. You've assessed everything. So how do we report now? So the guideline, as we have mentioned this image earlier on, you have put in all these necessary things: clinical data, specimen type, gross description, light microscopy, IF, EM, okay, special studies if there was, and you need to highlight the comment and diagnosis. Now we have come to the diagnosis part of it. So how do we write a final diagnosis after this thorough assessment? Make it clear and concise. Do not fumble in the diagnosis with too many elements, so much so the clinicians are confused. If you have multiple relevant diagnoses, please list them out separately. This one need to be addressed. So ultimately, at the end of the day, the final diagnosis is the most important. So to come up, you have to go through that meticulous assessment that we just went through. Okay. So preferably, we should be all standardized in the whole country. But of course, we are variable people. So variable people have different styles and preferences. So sometimes that's a bit difficult. So hopefully we will try to make sure that everybody is almost following the same concept. So first and foremost, you write the disease entity. So it's IgA nephropathy, you write IgA nephropathy. Okay. If you don't know the disease entity, then you have not come to a conclusion, but you know it causes a lot of immune deposition, then you may want to consider the word immune complex GN. If it doesn't cause any stains or any immunocomplex, then you want to consider things like pauci-immune GN. You can write that, provided you have no elements to suggest a specific disease entity. Okay. And if you have two distinct processes contributing to the renal dysfunction, please highlight. That means you have more than one primary disease. For example, IgA nephropathy and ANCA glomerulonephritis. Okay. So for point number 2, your basic pattern of injury. As I have already elaborated all the pattern of injury. Now, many of your reports don't have this, It's very good that you need to put in this basic pattern of injury. I've highlighted about 6 or 7 basic pattern of injury. Please include it in your report. You need to identify the basic pattern of injury. Either is MPGN pattern, is FSGS pattern, sclerosing pattern, necrotizing pattern. Please put it in your report. And then you need to identify whether it's focal or diffuse, and segmental and global. That one you need to identify at least focal and diffuse. Okay. If you have crescents, you can highlight them. If you have multiple patterns, you may also want to put in, for example, diffuse proliferative pattern with sclerosing, diffuse proliferative and sclerosing pattern. So you have 2 patterns. Please do it. If a diagnosis which has only pattern is highly not recommended. Try your best to find out the etiology. This is not recommended. For example, we do often keluarkan this report saying FSGS pattern because we don't have a conclusion. Yes, it is preferably not recommended. It's especially when we can't come to a conclusion. Try your best to find the etiology. Standardized scoring and classes need to be included. Please don't forget, if you're dealing with IgA nephropathy, please put in your Oxford classification, lupus, ISN, RPS. We have a few, like for diabetic, you can also put your TERVT, ANCA also they have got one, so you can also put in. IgA nephropathy Oxford classification is not used for pediatric age group because it's not validated. So don't use Oxford classification for children. Use it only for adult group. Okay. Okay, these are clinical modifiers. Clinical modifiers means you already know the etiology. Basically, this is contributed by the clinician. So if you have, for example, an infection-related GN that is IgA dominant, a very confusing handful of diagnoses. Why? Because this is based on IF, it's IgA dominant, and also has got some IgM positivity, maybe surface for infection you're thinking of. But you already know the underlying disease is Staphylococcus infection. So you know the pathogen and you know the main site of disease. Then you can put in all this. This is called a clinical modifier. Okay, so for example, ANCA-associated glomerulonephritis. You know ANCA because the ANCA results are out and the clinician has already identified the ANCA. Otherwise, it will come out as pauci-immune necrotizing glomerulonephritis. When you know it's ANCA-associated, you can straight away put it in. Do not have to beat around the bush. So additional information, you want to put in the proportion This one, you can put it under comment, proportion of global percentage of global sclerosis, segmental sclerosis, your percentage of IFTA, your severity of vascular. This one, you can put it under comment. I generally put it under comment, okay? So it's a good practice to put it under comment. Now, if you have a secondary diagnosis, coexisting lesions, sometimes you have a secondary diagnosis. For example, diabetic nephropathy. You may have IgA nephropathy with diabetic nephropathy in the background. So you put it in. This is a second diagnosis. It's not contributing really strongly for the first diagnosis. You may have certain other areas like tubular, interstitial, or vascular findings, which may contribute or unrelated to the primary diagnosis. For example, you may have IgA nephropathy with acute interstitial nephritis. For example, I'm giving you, or you may have an arthroembolic disease. So that becomes a secondary diagnosis. Please put it in as well. Okay. And you may have other findings like TMA in a lupus. This TMA, if you know it is caused by anticardiolipin or antiphospholipid or any form of anticoagulant disease, then you can actually put it in, but it's actually related to your primary disease. You can highlight. It's not wrong lah. Okay, for example, other than that, like for example, tubular interstitial inflammation or acute tubular injury, that is a component of primary disease. Some people like to put it into the main diagnosis. I would just put it into the comment. So if you do that, it's also fine. So we don't clog up the main diagnosis so much so they're confused reading the main diagnosis. And you may have, although it's a GN, the main diagnosis may not come from a GN. So you may want to highlight. So it could be like, the main diagnosis is contributed by the tubular interstitial compartment or a vascular region, for example. So you may want to put that in as well. So the last part of it, so what do you want to put under comment? So pathologists need to address all clinical concerns. If you're concerned about something, put it inside there. If you have limitation in assessing this biopsy sample due to sampling or technical issues, please highlight. If you can compare a previous biopsy, especially for the patients who are undergoing aggressive treatment or immunosuppression, you will need to highlight them. You need to look back at your previous biopsy and comment on that as well. Okay. Please apply all your classification scheme, for example, Oxford or Columbia or ISN RPS. Please put it in under the comment. If you don't want to put it under the final interpretation, you can put it under the comment. Okay. And then you need to summarize basically a biopsy finding. Whatever you've seen, you summarize it, which is relevant for your clinical presentation. Don't put unnecessary things inside the comment, okay? And if you have any other differential diagnosis, in which you have two different diagnoses, but you want to favor one, maybe you have a chronic change with an active change, but you think that this condition is more chronic, then you want to highlight that. You can also favor that in your comment. And other relevant references, perhaps you have referred to something you want to highlight, you can also put it in. So in a nutshell, these are all the things that we put it into the comment. And I hope that everybody follows through. I just give you three simple examples. So IgA nephropathy, primary disease is IgA nephropathy, pattern of injury, diffuse, mesangial, and focal segmental endocapillary proliferative and sclerosing GN. So it's very complicated. There's a lot of things here. And you have the Oxford classification here. And then you have all these additional features that you put in: focal, global sclerosis, moderate tubular atrophy, interstitial fibrosis, mild arteriosclerosis, a lot of things inside. And you have a secondary diagnosis as well. Maybe patient also has a diabetic nephropathy. But my final diagnosis, I will just put in IgA nephropathy. I will lump up all this into the comment compartment. So C comment, so you put it inside a comment. The second example is lupus. Now for lupus, slightly different. If you have a primary diagnosis of lupus and maybe got TMA as well, and this is the pattern of injury: diffuse, proliferative, sclerosing, and with crescents, and then got membranous on top of it. Then you have your classification, ISN RPS, what are the classification, and then all these additional findings that you find, all your IFTA and everything. So my final diagnosis would look like this: diffuse membranous with active, or you can put proliferative, chronic pattern, consistent with lupus nephritis, ISN RPS class 4, AC, and 5 with TMA. So this is how I put it in. So the final diagnosis is pretty long because you put in a bit of the classification as well as the pattern of injury. This one is crucial for lupus. So all your lupus reports should preferably look like this. And the last example is, for example, an MPGN pattern. You know this is a hepatitis C associated. The clinicians informed you, you have relevant, what do you call, antigens positive, the levels are there, the clinicians have already informed you, you can hear the recordings and everything, and you know very well the duration of disease is correlating with the finding as well. So if the pattern of injury is MPGN pattern, this is primary disease will be immune complex mediated glomerulonephritis. So all these additional findings are also there, but I will put it under the comment. But my main final diagnosis will be immune complex mediated membranoproliferative glomerulonephritis, hepatitis C associated. So that's how we write it down. So basically that's how it looks like. Okay. So take home message is that we try our best to standardize the biopsy report so that this will reinforce the systematic approach to the evaluation of the biopsy. Hence, this makes it more accurate. Your diagnostic approach is more accurate. So I think that's all. I know this is quite heavy, but at least you have an idea of what are the things that you will need to put into the report, because when I receive a lot of referrals, they are all kinds of reporting. And I think if all of us can keep it onto the same, if you're reporting, if you're in a center and you are reporting, you're the main person reporting, or all those people who are reporting all over the place, and we can keep it like systematic, I think this should be quite helpful as a guide, and hope you will provide a better standardized and a more systematic approach so that it's a diagnostic accuracy for us and for the clinician. I think that's about it. These are some of our references. Okay, thank you very much.
Thank you very much, Hema.
Yeah.
That was quite a wonderful talk, very comprehensive, covering all of the necessary basics and perhaps more advanced stuff. At the moment, we don't have any questions yet, but I just wanted to know what your comments are, because as opposed to regular surgical pathology, the technical aspects like the quality of the staining, the sectioning is very, very, very important in renal pathology. I believe a little bit more so than your routine surgical pathology, because you can often get away with less than perfect stains, sections that are a bit thick. But in renal pathology, you probably wouldn't want to play around so much with that and risk assessing like thicker sections, so on and so forth. So yeah, if you have any comments on that.
Yeah, true. I totally agree with you, Heidi, because many at a time, people make mistakes when your staining is not done properly. So let's say if your tissue is too thick or your staining is inadequate, and you can miss even simple things like membranous GN, you don't see the proper silver staining, you don't see the proper MT staining, and then you miss the diagnosis. So staining at each of your center is a very crucial thing. And for each of us as a pathologist in your own center, if you know that this is an issue, you have to take some initiative to validate, to make sure you improvise. And if your staff can't do it, you can send to places where they can learn or improvise their methodology of doing it. I think this is a very important point as well. Truly.
Right. Hema, I think we have one question in the chat box.
Okay.
Okay, we have a question from Santia Mutusami. Sorry, Santia, I don't know where you're from. But basically the question, the first part is, Dr. Hema, why do we do PAAG stain times 2? That's the first question. And the second one is also, what's the difference between 24-hour urine protein and UPCR/UPCI? Which do we follow? I'm confused. Help, Santia, please, Hema.
Okay. I love both. I'll answer the second question first. I love both. Your 24-hour urine protein, I love to know what is the 24-hour urine protein. Anything more than 3.5 grams, they are significant. And we have been, actually over the years, we've been very comfortable with this 24-hour urine protein. So it's a very good assessment. But the thing is that to do 24-hour urine protein, it's quite a hassle for the patient. The patient has to go through the 24-hour process of doing it without cheating. So that's a bit tricky. So now they have a spot test. I think it's a one-off spot test where you can actually check for urine protein creatinine index or ratio. And you can quickly assess level of protein. But the thing is that when you get the results, you need to know how to move around your decimal point to get the exact amount of protein. So that one you can liaise with your clinician and the laboratory that you are in whichever hospital. So it may not be the same at all hospitals, even if we are all in Malaysia, it may be a bit different. So that's the benefit of doing like it's faster and straightforward. But of course, I love both. Both of them will help you in addressing the extensiveness of the proteinuria in the patient. But then again, your 24-hour urine protein has to be done properly lah. Now, the first question was what again, Heidi?
Well, Santia wants to know why you're doing 2 slides for the silver stain.
Right. Good question, Satya. Satya, you've been with us before. I believe you must have seen this as well. As I told you earlier on, we do a few slides, and when we take out the levels, we put in 2 levels in the first slide, followed by another subsequent 2 levels in the second slide. Now, they all have different stains inside there. The reason being is that if you, for example, let me give you a condition like, for example, FSGS, you may see something looks like an FSGS in the H&E stain, and then when you come to the first round of silver stain, you may see it looks more like an FSGS. Eventually, you need to confirm it. When it comes subsequently to the following silver stain, you may finally find a full-blown FSGS. Now, the meticulous doing of many levels in many stains are basically to enforcing and to making sure that we don't miss those lesions, or any lesion for that matter. And repeatedly, let's say if you've already seen something in the first level, after a few levels, that particular lesion becomes more prominent in a subsequent level. That's basically the reason why we're doing a few levels in different manner, in different numbers of slides. So I think that's all. It's basically a method of identifying lesions, basically. Yep.
Right. If I could just add on one comment, I work in Alustar, and our chemistry lab does a different set of units for the UPCI, sorry.
Okay.
And the biochemistry lab in Sungai Petani, which is essentially our next door neighbor, they do different units. So, sometimes it does get a bit messy that way, and I have to stick the conversion formula in front of my face every day just so I don't get the numbers wrong. So, I understand it can be quite difficult.
Yeah, it can be quite difficult, but if you know what is suitable for your lab, I think it's good so that you can, identify these numbers very quickly.
Right. Okay, Hema, we have a few more questions.
Yep.
There is Aznim Hani Ramlan, who is asking whether we could put eosin during the grossing of renal biopsy. I think it's like, how you drop a bit of color onto your biopsies just so people don't over trim?
Yeah. Yes, the answer is yes. Basically, the tissue is, see-through Lucina. So we definitely put eosin to identify the tissue. It should not affect your tissue biopsy. There should not be a problem. Yes, Asmin, you can do that.
Right. And another question still from Amizatul. Hi, Dr. Hema. How to differentiate between true crescents and pseudo crescent? Aha. Lifelong dilemma.
Okay. Amizatul, is it?
Yes, it is.
Keep seeing a lot. That's the only way to do it. Actually, true crescents, I mean, the term crescents, if you're referring to a cellular or fibrous cellular crescents, basically breach of your capillary wall. You have an immunopathological inflammatory condition going on in that location, where there is a big breach of the GBM at that area and influx of inflammatory cells. You may have a bit of fibrin there and things like that. So that is a true crescent formation. Now, to demonstrate that breach of GBM, it is almost near impossible. If you're lucky, you can get to see them lah. But for pseudocrescents, is a different scenario. So basically, pseudocrescents means proliferation of podocytes or proliferation of even the parietal epithelial cells, which kind of like conjugate themselves and make it very big and form a big, like a crescent. They are like a crescent. That's why they call pseudocrescents, but they are basically made of epithelial cells. You see, in original crescents also, there are combination of cells. You may have inflammatory cells, you may have the endothelium, You may have even podocytes reacting at the same place. So a combination of cells. It's a bit tricky, but if you can identify what is underneath the lesion, that means if you have a segmental lesion like a collapsed tuft, or what's, for example, a collapsed tuft at the area of the tuft where is just beneath the pseudocrescent, that would favor towards a pseudocrescent rather than a crescent itself. Crescent itself, you should not be having any collapsed tuft. It should be just the tuft or the tuft getting smaller, and you have a nice crescent forming in that area. So this is very difficult for me to explain just in words. I'll have to show you in some images and and enhance in that lah. But that's in a nutshell, you can do it. Now, if you ask me if you can do an immunohistochemistry, yes, you can. It can help you, but which one would you want to do? That would be the tricky question, because some of these podocytes pick up different immunohistochemistry. You can do the usual epithelial marker, but surprisingly, some of your crescents also will show you some markers. So you can do some epithelial markers to highlight the, because as you know, the visceral epithelial cells or the podocytes, they're all basically epithelial cells. So you can do some WT1, you can do some epithelial pan-CKs, you can do those markers to highlight the crescent. So I think that's one quick way or crude way of doing it lah. Yes. But other than that, you have to keep looking at many to make sure you don't miss one.
Yeah, those are tough, aren't they?
Yeah.
Okay.
Time periods.
I have another question for you from Nur Hafiza Wagiman. Hello Fiza, lama tak jumpa. Basically, hi Dr. Hema, is immunofluorescence finding of IgA 1+ or plus minus enough to conclude as IgA nephropathy?
Okay. You preferably, I know I find this tricky as well. Those days, I would say 2+ and above is the best. You need 2+ and above, then you will consider it as positivity. But we know that IgA, you can also have a smaller amount of deposits. So you still can have 1+ to 2+. But if you have something between plus, minus, and 1+, and the amount is not that much, and you're seeing it in all the glomerulus, and look back at the history, look back at the morphology, if it is a significant mesangial hypercellularity, if let's say there's no mesangial hypercellularity, it's just a very quiet looking mesangium, and you have this unusual plus minus 1+, perhaps you want to highlight the interpretation as with mesangial staining or with mesangial deposits, rather than to just jump and call it IgA nephropathy. He or she may become IgA nephropathy over time. I can't tell you that for sure. Or maybe this is just a bystander that is being picked up that I can't tell you for sure as well. So there is a possibility. But if anything that's 2+ and above, at least 1+ to 2+, 2+ and above, where the clinical scenario fits and the morphology also fits, I think I would call it IgA nephropathy. So this one, if you have the benefit of doing EM, you can confirm the the electron dense deposits in the mesangium. Otherwise, I would stick with this this way of reporting. So if I'm confident and it's adequate, 2+ and above, I'll call it IgA nephropathy. Anything less than it, I will put there with IgA deposits. So they do know that this patient has some unusual staining over there. Okay, for them to correlate clinically.
Okay. Oh, okay. Hello, Moha. Assalamualaikum.
Salam.
You have a question for him, huh?
Tadi lagi.
Hi, Moha.
Yeah.
Sorry.
Hi, Hem. Much very good. I like the way how you present this presentation. I wonder. I think someone asked this. Dr. Zarka asked something same as me actually. I just want regarding EM lah, because we what we call it, request from clinician to send EM center if possible. Sabah to send EM to your center.
You're asking whether we can send, is it? Is that asking, Moha?
Yeah, we from here.
It's like this. Right now, Moha, Thank you for asking. We have just opened this pathway, this open service, this service since last year, like what Heidi has just mentioned. I think 31st of May or beginning of June last year. So we did a trial run we are doing it for every case so that we build our learning curve as well as strengthen the EM services in NIH. But out of interest, a lot of people want to send the electron microscopy tissue. Number one, it's also free lah. So we are doing it in that manner. For time being, I'm able to cater for HKL and HTA, the pediatric hospital in HKL. But what happens is that if there is a request, let's say if you have a request where a patient is going for donor sampling, because eventually the patient will end up with us, and if there is a special case where it's a pediatric unusual case, or you think that this case is in which the EM has to be a very crucial diagnostic, then you can just call me and speak to me directly. Then we will try to make some arrangements. Actually, I have already done for Sabah, I think on 2 occasions, if I'm not mistaken. They were donor samplings actually. So the donor wanted to donate to the sister, the elder sister, so in which the clinicians contacted us and we made the arrangements for you all. And we have already reported the EM for the patient and we already successfully done the transplant after that. So we've done this on 2 occasions for Sabah as well. So we'll be doing this so far. And must bear in mind, I'm alone here. So I can't open fully and we won't be able to cope the influx. So it has to be on staggered lah. I mean, if it's from outside. There are a few hospitals from outside already sent to us upon request. So, if I think it's okay and if it's a valid reasoning, we will open it. We will give it to you. We will do it to you.
Okay, let's say a clinician request for EM. Are you, do you prefer for us to send the previous slide, means the diagnosis, like just now you say IIGA?
Yes. If you're sending for EM, what you will need to do, you have to send, it's best for you to send the whole set. That means the tissue for paraffin, the IF, if the IF cannot be done, if you can report it there, it's also okay, but send me the images, and the tissue EM. So I can see the whole thing so that I can correlate the findings. Just EM alone, I can't do it. I need to see the whole thing.
So means let's say clinician request for EM, so they need to do what we call it, new biopsy for EM. Because
yes, exactly.
So is it for you? You prefer we send the previous previous renal biopsy first, and then you decide whether this patient really indicate for EM.
Oh no, you don't need to do that. It is up to the clinician. If they think it's suffice, then they can call and discuss with me. Then I can let them know if we think so. I don't need to really have a look at it. I mean, that need not to be the necessary, unless they have a issue about the previous report. Then we can have a look at it lah. But it doesn't have to be in that way lah. I mean, if they think it's sufficient and I think the reasoning is valid, why not?
Okay, thank you very much.
Okay, thanks.
Okay, basically, I think that covers Zarka's question as well. And Zarka was asking the exact same thing because she seems to have a request from the nephrologists there in Terengganu.
I see.
So the answer would be exactly the same as what you discussed with Moha just now.
Yes.
We have one more question from Aznim Hani. Regarding, Aznim was the person who was asking about dropping eosin onto the tissue. Yes, and she says that she's having some problems in her center recently, and that if our center sends IF to another center and it's unsatisfactory because only the medulla is seen, then can we do IF on, I think, this formalin fixed tissue, and again it's inadequate? How do we report?
Okay, Asnim, actually, I have been reporting, this is Putrajaya, right? I've been reporting a number of your IF samples, and I did notice the number of the cases were actually inadequate. So you need to feed back to your clinician. Basically, it's what do you call? They have to improve on sampling the tissue lah. They have to improve, because ideally the gold standard is you would want to do IF on fresh tissue. I must remind you all, doing IF on protein pronase digested paraffin sections are not all that great, and it can be very confusing, and it is also how do I say, can mislead you to a certain different diagnosis as well if you're not picking it up correctly. So I would advise you to please let your clinician know about this frequent inadequacy, because I'm the one reporting for you all currently, so I can see quite a number of it is inadequate. I was also quite surprised. So you have to inform them, because this one is actually need to improve quality basically. They have to improve their way of doing the biopsy on their side. Okay. Number two, if you want to do a pronase digested paraffin section, you can do, provided you think that this is really relevant. Now, let's say if you can't do, then please give a pattern of injury description. That means pattern of injury interpretation, like I have already described to you. You can put an exudative, let's say for example, diffuse exudative glomerulonephritis, or you think it is diffuse proliferative glomerulonephritis and stuff like that. But in your comment, you can highlight that you don't have this one to correlate and confirm the etiology. So hence they have to improve their way of doing the biopsy, or how is it, that would be the best way to do it. Now, previously when we didn't have pronase as well, we also had to do that at some point. Of course, we had the benefit of IP before we started this pronase thing. There was a lapse of time when we didn't have, then we had to do this kind of pattern description. We have no choice. So that's one way to go about it. So when it is frequent, they will have to improvise their way of doing the biopsy, or, to get more tissue somehow. Perhaps, I do not know whether they are taking the tissue and then cutting it on their own blindly and giving you all. I'm not sure whether that's being done. You need to talk to them and see how is it actually, being handled. Like on our side, I asked them thoroughly what they're doing, how they do it. And I think Heidi is in fact gone and checked on them. Exactly, right, Heidi? You have actually checked on them, like how are they doing it?
Yes, I did.
And the pediatric team have a different way of doing, the adult team have a different way of doing. It's quite surprising.
Indeed.
Yeah, so this one you can talk to them and communicate. The communication is really important, and you have to let them know, because if they keep doing this over and over, and the underlying etiology will be all pattern only, you have no etiology. So it will impede on their way of managing the patient. So this one comes down to sit down and communicate, and you have to sort it out. But for time being, I think you have to do a pattern morphology description for the interpretation part. That much we can do now.
Yes, indeed. And if I can just add on, sometimes when you get two cores and one core is shorter than the other, and then your IF sample sort of looks like it came from that shorter core, I mean, you can just figure what happened most of the time. But yeah, I think communication with your nephrologist is really important. On a few occasions, I called up the nephrologists here because there were a string of biopsies that just had very unsatisfactory IF sample. And they did something about it for sure, I think, and it definitely improved after that.
Yeah.
So I think it's 11:35 now. Yes, yeah. Moha lagi. Baik Moha, sila.
Saya nak tanya ya, regarding IF on paraffin plot. This is new technique, isn't it?
Yeah.
So how many centers have done this? I think Kuching and HKL, is it?
HKL doing it. Kuching, I am not sure.
I think Yusri did that.
Yeah, Yusri is doing it. Yes, Yusri is doing it.
So I think we need to start it in Sabah because we have problem with lot. I just want to know roughly what do we need. Maybe budget, or maybe I think you can mention it here roughly. Maybe just later. Is it possible? Is it we have to learn something new?
Yes, you have to learn how to do it. And trust me, Moha, initially to get it right, it is a lot of, how do I say, technique. So if you want to get somebody to send over to learn how to do it, I think that's better. So you learn how to do it gently. And even now also, despite so long doing it, we still get on and off, incorrect findings and things like that. And we have to repeat that also. So learn it correct on the first round, it's important. I think that's one. Budget is not too bad because basically you are just antigen retrieval bag and then you are restaining bag. So the one is not too bad. I think the one your team can liaise with our technical staff here to get it. That one is not too bad, but the method of doing it, the technicality is very crucial lah.
So it's better for us to send our technology.
Yeah, you can get someone to train. I think we have a few. Heidi, didn't you send somebody as well?
Yeah,
Like,
I just sent one of my
Ah.
MLTs over.
Yeah.
The additional reagents that we needed, only 3 extras: the goat serum, the bond diluent. And there was one more thing I can't
Yeah.
remember. It's only just 3 extra things.
Bond
The rest
nitrate,
is the rest well, if you're already doing IF, you already have it. We're going to start it very soon because we only just received the reagents. And but the sectioning is a bit delicate. It's 1 micron thick.
Yeah, it's
and
1 micron, Mohan.
Yeah, and it's quite a bit of I think technical wise they have to get used to doing it that way, the proper way. So yeah, but yeah, I suppose we should all be mentally ready for all of that work in order to optimize
Yes,
the staining.
because most of the time we don't have gloom in the what we call fresh eye.
Okay.
And then we have so plenty of what we call it gloom in the paraffin block.
Okay.
Oh dear.
Yes,
Usual dilemma.
unfair for the patients to repeat biopsy just for what we call it.
Yeah, exactly.
Yes, it's painful and also it's a waste of time and everything. So maybe we should start in Sabah in future. So I will live with you and maybe we have to find the budget to send our technician there also.
You don't have to attach for long actually, just for a while. But
Yes.
once you have got it, then you can start it lah with trial run and then get it going.
Okay. Thank you.
All right, Hema, I think can that be just the last question? Because it's already 11:38 and it's the beginning of your weekend. So yeah, thank you very much, Hema. Your pictures were absolutely totally stunning. Your talk was excellent. So I thank everyone for spending your time with us today. And I hope everybody has learned something from the talk. I definitely enjoyed the talk so much. And thank you again. Thank you so much, Hema. Thank you, organizers.
Okay, thank you so much. See you all.
Thank you.
Bye-bye.
Thank you, Dr.
Thank
Emma,
you.
and thank you to our moderator today, Dr. Heidi,
Yes.
for the excellent talk and the flow of the whole topic today. And for the upcoming session, we'll be having Dr. Nur Jehan in the house and representing soft tissue and bone pathology with the title of Giant Cell Rich Lesion Overview and with a new concept. So I hope all the participants can join and cheer Dr. Jehan in the upcoming events. And thank you again, Dr. Emma, and thank you, Dr. Heidi, and see you all soon.
Thanks.
Thank you.
Bye-bye.
Thank you.
Thank
Hema. Bye,
you.
everyone. Thank you.
Yeah, just want to add, this is the August session will be the last lecture of our first IAPMD weekend live of the first session. We will start our second session for September 2020 onwards. So for those who has registered and paid, please kindly stay tuned. And for those who are still interested to join us, we appreciate your continuous support. Thank you.
Thank you, Dr. Emma.
Okay, bye.
Bye. Thank you.